replacement patients, how do we prepare them? I request Dr. Amzad Hossain to give his very important talk. How do we prepare for the valves, patient for the valve surgery? Dr. Amzad Hossain.
Good morning, everyone. So, my topic is how do we prepare a patient for valve replacement? Normally, the patient with valvular heart disease presents with heart murmur, symptoms, and the incidental findings of valvular abnormalities on chest imaging and non-invasive testing. As the decision about the treatment are based on presence and absence of symptoms, a careful history is taken from all the patients in our hospitals, and also a detailed physical examination is performed to diagnose and assess the severity of the valve lesion. We perform ECG mainly used to confirm our heart rhythm, and chest X-ray to assess presence or absence of pulmonary congestions and other lung pathology. As AHA class 1 recommendation, we perform transthoracic echocardiography in initial evaluation to confirm the diagnosis, establish the etiology, determine the severity, assess the hemodynamic consequences, the morphology and the motion of the valves, associated the abnormalities like aortic dilatations, determine the prognosis, evaluate for timing of intervention. And left ventricular anatomy and function are characterized by the linear dimension. And it is the left ventricular linear dimension for echocardiography that have been used to determine the timing of valve operation. A semi-quantitative assessment of right ventricular size and function is usually made by visual subjective analysis. The Doppler TT is used for non-invasive determination of the valve hemodynamics. In stenosis lesion, stenotic lesions, the measurement of peak velocity, valve gradients, and valve area characterize the severity of lesion. Whereas in the regurgitation, it is the focus point, the jet geometry, regurgitation flow, transvalvular volume flow rates, and flow reversals in the atria and great vessels. The hemodynamic effect of valve lesions on the pulmonary circulation can be determined by the tricuspid regurgitation velocity. As class 1 recommendation, in our hospital, transthoracic echocardiography is done in patient with any change in symptoms or physical examination findings to determine whether the etiology of the changing symptoms and signs are due to progression of the valve lesion, deterioration of the ventricular response to the volume pressure or pressure overload, and another etiologies. The periodic monitoring of the TTE is done in asymmetric patients to prevent the irreversible consequences of the severe valvular heart disease. At minimum, the follow-up should consist of a yearly physical history and physical examination and frequent 2D and Doppler echocardiograms. This chart shows the frequency of the echocardiograms in asymmetric patients. And cardiac catheterization is done as per recommendation when the non-invasive tests are inconclusive or where there is a discrepancy between the findings on non-invasive testing and physical examination. And the exercise testing is done in the asymptomatic severe valvular heart disease to confirm the absence of symptoms and assess the hemodynamic response to exercise and determine the prognosis. Other ancillary tests like transesophageal echocardiography, computed tomography, and cardiac magnetic resonance imaging may be required to determine the optimal treatment for the patient with valvular heart disease. After the clinical and lab evaluations, we define the severity of the valve lesions, which depends on the correlation of findings on the physical examinations and data from comprehensive transthoracic echocardiography. These are the stages of the progression of the valve disease. And the purpose of defining the severity are to describing the natural history of the patient with unoperated valvular heart disease and determining the prognosis and set the treatment. And all patients being evaluated also undergo guideline-directed medical therapy for other risk factors associated with heart cardiac disease such as hypertension, diabetes mellitus, and hyperlipidemia. These patients are taking a drug therapy for mainly left ventricular systolic dysfunctions, which includes AC inhibitors, ARBs, beta blockers, restriction of fluid, diuretics, in the shadow of the clinical evaluation and investigations such as pro-BNP reports. The secondary prevention of the rheumatic fever is done in the patients with rheumatic heart disease, especially in the mitral stenosis. This chart shows the prophylactic drugs and the duration of the prophylaxis here. And infective endocarditis prophylaxis is also done in the following patient at high risk of adverse outcome with infective endocarditis before any dental procedure, which involve the patient with prosthetic cardiac valves, patient with previous infective endocarditis, and structurally abnormal valves. Now, if the patient has atrial fibrillation, those patients have to evaluate the risk of thromboembolic events and should be treated with atrial fibrillation. The anticoagulants are the vitamin K antagonists are the anticoagulation drugs of choice in the patient with rheumatic mitral stenosis and mechanical heart valves, whereas the novel oral anticoagulants are the alternatives of the BKs in the patient with bioprosthesis valve more than 3 months after implantation or the native valvular heart disease excluding rheumatic mitral stenosis. There is the recommendation for the drugs for atrial fibrillations. And the flow sheet also shows the treatment plan of the atrial fibrillation. After all evaluation, we in our hospitals evaluated the surgical risk using the online tools such as STS or Euroscore 2 and discussed before the procedure as a part of shared decision-making process. This chart shows the risk assessment of the surgical valve procedure in every procedures. Then if any other pathology detected in other systems, the patients are evaluated by the consultant concerned discipline thoroughly and proceed to the next steps after their clearance. This is the recommendation for multidisciplinary heart valve team. In our hospital, a dedicated combined team consists of surgeon, cardiologist, and intensivist and anesthesiologist. The team evaluates all the patients proposed for surgery twice a week. And the frailty assessment for at-risk patient is done routinely. Patient towards the higher end of the risk spectrum for whom intervention would be futile or associated with high likelihood of poor outcome are identified. Then the final decision to intervene as well as the type of procedure recommended is based on an assessment of patient procedure, operator specific short-term risk and long-term benefits, and surgical mortality rate and major morbidity risks are done. That's all for our preparation. Thank you.
Thank you very much, Dr. Amzad Hossain, for your nice presentation. Now I would like to invite Dr. Tanvir Zaman, and he will talk on a very important topic, that how we establish standard CPB and wean off from CPB. If you have any question or comment,